day, a patient asks her doctor, "Doctor, what's faster, lightning, light, or diarrhea?" The doctor says, "What? I have no idea. You tell me." She says, "Well, the answer is diarrhea." The doctor asks, "Why?" She said, "Well, because the other day I ran like lightning to the bathroom, turned on the light, but alas, the diarrhea was already there." Thank you so much. I'm making a list of the worst places to get unexpected diarrhea. Number 2 may surprise you. And ever wondered, how is diarrhea hereditary? Because it runs in your genes. That's denim genes. So very good morning, everybody. It's Dr. Ryan here again with another high-impact algorithm in internal medicine. I want to formally welcome you to the section on gastroenterology. Yep, this is our 33rd algorithm in internal medicine, our first in gastroenterology, and we are running with the topic of diarrhea. You see what I did there? Running. Anyway, let's get started. Diarrhea describes an increase in water content, volume, or frequency of stools, typically occurring at least 3 times in a 24-hour period. Now, acute diarrhea lasts less than or equal to 14 days. Persistent diarrhea lasts more than 14 days, and chronic diarrhea is above 30 days in duration. So diarrhea, as we know, as per the algorithm, can be inflammatory, osmotic, secretory, or can involve intestinal dysmotility. Now, inflammatory diarrhea can be further stratified into infectious and non-infectious. Infectious can be further stratified into invasive, non-invasive, and non-invasive into viral, bacterial, protozoal, and so on. Historical features such as exposure, example medications and travel history, time course, example acute or chronic, and stool characteristics, example watery, bloody, or fatty, are helpful in determining the etiology of diarrhea. Now, infection is the most common cause of acute diarrhea. Chronicity should broaden the investigative focus. Inflammatory diarrhea is caused by either invasive infections or non-infectious conditions, and is associated with the presence of polymorphonuclear leukocytes or leukocyte proteins in the stool. Persistence of diarrhea despite fasting suggests a secretory cause. That is a big clue. And the stool osmotic gap can be helpful in distinguishing between osmotic, where the osmotic gap is above 50 milliosmoles per kg, and secretory, where the gap is less than 50 milliosmoles per kg, diarrhea. Okay, so let's get started. This is quite a heavy one. So inflammatory diarrhea, we said, is infectious, non-infectious. So under infectious, invasive, non-invasive. So let's look at non-invasive causes of infectious inflammatory diarrhea. The viruses, the infamous ones is norovirus, rotavirus, adenovirus, astrovirus. I think coronavirus can also cause it, so watch out. Bacterial etiologies, there's 9 causes of non-invasive infectious. Clostridium difficile, which is the classic antibiotic-associated diarrhea. Bear that in mind because we're going to revisit this concept in the subsequent slide. Clostridium perfringens, which causes so-called gas gangrene, then Staphylococcus aureus, Bacillus cereus, E-tech, which is actually enterotoxigenic, Escherichia coli or E. coli, and E-pec, which is enteropathogenic E. coli. Listeria monocytogenes, watch out for this one, because when this one causes septicemia, it can also result in meningitis, okay? Vibrio cholera associated with the typical rice water kind of stools. Trophorema whipple, which can result in an infiltrative sort of disease, okay, cause Whipple disease. Now, protozoal causes, the mnemonic here I like to remember is MAGIC, M-A-G-I-C, which is Microsporidiosis, Entamoeba histolytica, Giardia lamblia, Isospora belli, Cryptosporidiosis, or or Cyclospora cayatinensis, or Cyst Isospora belli, right? So that's that. Well done for infectious. Then non-infectious inflammatory diarrhea. Here we look at the IBD, inflammatory bowel disease spectrum, where we're looking at ulcerative colitis, Crohn's disease. Also remember that because we're going to be revisiting those concepts in a subsequent slide. Ischemic bowel, don't ever forget about this, right? Malignancy, as well as radiation and toxins. Now, when we're looking at osmotic diarrhea, right, there's some kind of osmotically active solute that is pulling water and fluid into the intestinal lumen, right? So here you think about people who have lactose intolerance. Medications can cause it, non-absorbables, bacterial overgrowth. An example of this would be tropical sprui, celiac disease, which is gluten-sensitive enteropathy, okay? Where there's villus atrophy and so forth. Now you look at the anti-gliadin and anti-endomysial or transglutaminase antibodies, pancreatic insufficiency, sorry, Got a frog in my throat today. Oh dear. Pancreatic insufficiency usually associated with fatty stools, which are foul-smelling and difficult to flush away. Ew. Right? Short bowel syndrome, choleric diarrhea, which speaks to the persistence of bile acids and bile salts in the intestinal lumen, tropical spirit. Right? Secretory causes, and the classic example here, or the classic giveaway clue, is that the diarrhea persists even when the patient is fasting. So here we look at medications that can cause a carcinoid. Bear this in mind. We're going to be revisiting this in a subsequent slide. Gastronoma and glucoconoma, which are both, endocrine tumors involving the pancreas, VIPoma, as well as mastocytosis. Then that which is diarrhea associated with dysmotility. Here we look at irritable bowel syndrome. We look at the Rome criteria at that. Medications, diabetes, known for causing diabetic gastroparesis, and watch out for that. Thyrotoxicosis, classically associated with diarrhea as well. Scleroderma, and the reason why I get in scleroderma is because of small bowel intestinal overgrowth. Okay, that's the main reason you get diarrhea in scleroderma. And amyloidosis, don't forget. So it's whopping 6 causes associated with this motility, 6 with secretory, 9 with osmotic, 31 with inflammatory, divided into infectious, non-infectious, invasive, non-invasive, so forth. Give me a whopping 52 etiologies or possible etiologies for diarrhea. That's crazy. All right. This is a fun diagram from Mr. George Muniz, once again, over at medcomic.com. Clostridium difficile infection. We know this causes antibiotic-associated diarrhea. So this is a fun diagram looking at these naughty C. diff bacteria sitting on the intestinal epithelium, sitting in the lumen. So Clostridium difficile contains endospores that can survive the acidity of the stomach and reach the large intestine. Okay, and the normal gut flora is altered by broad-spectrum antibiotics, most notably clindamycin, cephalosporins, ampicillin, amoxicillin, and fluoroquinolones. The giveaway feature is so-called pseudomembranous colitis, which are yellowish plaques over damaged epithelium. It produces toxins A and B, which cause and mediate the mucosal damage. It flourishes in the colon, and the most common infectious cause is nosocomial diarrhea. Ew. Then this is a famous question, man. Inflammatory bowel disease, ulcerative colitis versus Crohn's. These are the salient features here. May involve, so Crohn's disease, as we say, may involve any segment of the GI tract from the mouth through to Uranus. I like the way they said Uranus. Prolonged diarrhea with abdominal pain, fatigue, and weight loss. The characteristic thing is that it involves skip lesions here, there, and everywhere. Right? Transmural inflammation, and it's often associated with anal fistulae, abscesses, fissures, and ulcers. So a couple of these characteristics contrast with that of ulcerative colitis. Here we have recurrent episodes of inflammation, but it's limited to the mucosal layer of the colon. It's not transmural, but it's limited to the mucosal layer of the colon. We have bloody diarrhea with mucus that involves the rectum by definition and extends proximally. Very important to also note the extraintestinal manifestations of inflammatory bowel disease, right? Oral ulcers, arthritis, spondylitis or sacroiliitis, very important. Episcleritis or uveitis involving the eye. Erythema nodosum, which is actually a form of paniculitis, pyoderma gangrenosum, hepatitis, sclerosing cholangitis, and thromboembolic events. All right, fantastic. Oh, sorry, skipped over there. To keep things fresh and exciting, let's do an OSCE question. So we got a 52-year-old woman has diarrhea, wheezing, and flushing reactions shown here, which seems to be associated with emotion and alcohol ingestion. So what is the best screening test? Is it urinary metanephrines, antimitochondrial antibodies? Is it antinuclear antibodies, skin biopsy, or urine 5-hydroxyindole acetic acid? So the answer here, I mean, if you look at the classic triad of diarrhea, wheezing, and flushing, this equals carcinoid, right? And the test that we do for that is the 5-hydroxyindole acetic acid, 5-HYA. Which one of the following likely would be most effective for alleviation of symptoms? The answer here is going to be D, somatostatin analogs. Just quickly a little bit on carcinoid. Carcinoid tumors metastatic to the liver cause flushing, wheezing, and diarrhea. The most common sites of origin are the terminal ileum at 90%, but you can also have lungs or bronchi, appendix, rectum, stomach. The heart is involved in about 50% of patients who have pulmonary and liver mets. Cardiac involvement usually involves the right-sided valve. So watch out for tricuspid and pulmonary regurgitation or stenosis here. Serotonin-like substances are responsible for the symptoms. Measurement of 5 hydroxyindole acetic acid is a diagnostic test of choice. CT or MRI is best for demonstrating liver mets. Somatostatin scintigraphy may help find lesions that are otherwise difficult to localize, and somatostatin analogs are effective for relieving symptoms, but they do not cause the tumors to regress. Okay. So as always, folks, just something to motivate you this morning. You know, Sir Winston Churchill once said, and I quote, that you will never reach your destination if you stop to throw stones at every dog that barks at you. We often heard the term, your attitude determines your altitude, and we have also often heard about the power of association, that bad company corrupts good character, and so forth. But what does the Bible have to say concerning this? I just want to make reference to the book of Psalm chapter 1. I know that many of us probably know this scripture off by heart. It says, "Blessed is the man who does not walk in the counsel of the wicked, or stand in the way of sinners, or sit in the seat of mockers. But his delight is in the law of the Lord, and on this law he meditates day and night." It goes on to say, "He is like a tree planted by streams of water, which yields its fruit in season, and whose leaf does not wither. Whatever he does prospers. Not so the wicked. They are like chaff that the wind blows away. Therefore the wicked will not stand in judgment, nor sinners in the assembly of the righteous. For the Lord watches over the way of the righteous, but the way of the wicked will perish." I'm going to say that again. The Lord watches over the way of the righteous, but the way of the wicked will perish. So, there you have it, folks. I hope that you have benefited from this algorithm, and I will see you tomorrow with another algorithm in gastroenterology. God bless. I'll see you soon.